Okay, welcome. Sorry for the delay, but DL has given us the green light and says that we are now up and live on YouTube, so we are ready to go. So committee, we're going to open up with the hearing on Senate Bill 170. And first off, we're going to have an overview from Jenna Moyer on the bill. Jenna?
Good morning, Mr. Chair, members of the committee. This is a brief over Senate Bill 170, and it relates to the Advisory Committee on Trauma and the Regional Council on Trauma, and these are located within the Division of Public Health of the Department of Health and Environment. And these entities, their basic function is to advise, report to, and discuss activities, information, and findings related to incidents of trauma injury or trauma care. And this bill would amend their statutes KSA 75, 56, 64, and 56, 65. Currently, in the law, there is an expiration date on when these entities were to review these incidents of trauma or trauma care. The privilege of those, oftentimes health records, would remain confidential, and in current law, this privilege would expire on July 1st, 2021, and this bill would strike that sunset, and so that those confidentiality protections would remain indefinitely, and that applies both to the Committee on Trauma and the Regional Council on Trauma. And with that, I'll be happy to answer any questions.
Ready? Do we have any questions for Jenna on the bill? Seeing none, Jenna, thank you very much. We will now move to proponent testimony. First up, we have Wendy O'Hare. She's the Trauma Program Director for KDHE, and she is testifying virtually. Wendy, welcome to the committee.
Mr. Chair and members of the committee. My name is Wendy O'Hare, and I am the Kansas Trauma Program Director, which is a program within the Kansas Department of Health and Environment. So the Kansas trauma system is made up of several different components, one of which is the Advisory Committee on Trauma. Their job is to establish and research the standards of trauma care nationally, and then enact those standards within the state of Kansas and make those recommendations to the Secretary of Kansas. They also, the Advisory Committee on Trauma also designates trauma centers in Kansas, and a trauma center, level 1 being the highest, level 4 being the base, and they make those recommendations also to the Secretary of Kansas Department of Health and Environment for designation of trauma centers. They also monitor data trends within the Kansas Trauma Registry, which is housed within our program. And they use that data also to aid in establishing the standards of trauma care. There are 6 regions within the state, trauma regions. The borders of those regions are aligned with the Kansas Board of EMS for better collaboration among healthcare providers and those partners. The membership of the 6 trauma regions are physicians, nurses, medical technicians, paramedics, and also and the regional councils assist their members with injury prevention, trauma-specific education. Each region has a budget, and they accept applications for funding for trauma-specific education. And the Advisory Committee on Trauma also relays information back and forth to the trauma regions for best practices. The Trauma Registry, again, it's housed within our program, and this is all de-identified patient information. All hospitals within Kansas are required to report their trauma cases to our registry. We do provide this registry at no cost to the hospital. And this data then is used to target mostly injury prevention activity in Kansas. So the peer review committee, which is the advisory committee on trauma, has a peer review committee, as well as each of the 6 trauma regions. And these peer review committees then meet together with healthcare providers who are directly involved in a trauma case, and they discuss best practices and opportunities for improvement from trauma cases that have happened in the localities. These peer review sessions happen in a closed door session. Any information that is provided within the committee meetings are protected, and we find that healthcare providers really do want to learn how to improve themselves in treating trauma patients. And this is the best way that we have found to offer opportunities for improvement, is to get together in a closed session and have open discussions about the care that was provided for that particular patient. We also know that in rural Kansas, there are so few opportunities for having those good discussions, just because the higher level of trauma centers are not out in Western Kansas. And so by getting together regionally, this offers an opportunity, the best opportunity to have these discussions. So our program has 2 statutes that have these sunset clauses that would protect care providers from disclosure during these peer review committees. And we are just asking that you support Senate Bill 170 to delete these sunset clauses so that these conversations can continue. I will also like to note that our agency introduced a mirror of this bill in the House, and that is HB 2158. And it did pass the House on February the 18th on a vote of 121 to 1. And this bill has now been assigned to the Senate Public Health and Welfare Committee. So I would just like to ask that you support Senate Bill 170 and move this. And I would be happy to stand for any questions.
Thank you for your testimony. And committee, we are going to hold questions until all conferees have had a chance to talk. Next up, we have Joseph House. He's a paramedic and the executive director for the EMS board. Joseph, welcome to the committee.
Thank you, Chairman Hildebrand, members of the committee. My name is Joe House. I'm the executive director of the Emergency Medical Services Board, which is your state agency responsible for the oversight of all EMS providers, ambulance services within the state of Kansas, and all things EMS related. We stand in strong support Senate Bill 170 and appreciate the opportunity to provide this testimony. I'm not going to repeat what Program Director O'Hare mentioned on here, but just to say that performance improvement only happens through unrestricted conversations. That's why the Kansas Legislature felt it quite appropriate to allow these peer review committees to meet in closed session, understanding that discussing personal private information, health information within a public setting is really not necessarily the best practice in the world, especially in the rural areas where it's probably someone that you know or someone else in the community knows. So this Senate Bill 170 makes those provisions permanent, allows that to continue going on in that closed session and not come back up for review again beyond that. And so as Program Director O'Hare noted, performance improvement is the key here. But I'd also like to point out that when things go very well, that needs to also be propagated out. And without the ability for the Advisory Committee on Trauma or these regional trauma councils to share their findings with the secretary, that's what this does. It just allows them to step out of that closed session, share the information that they find with the secretary and the secretary only. That can't be propagated back out. When the secretary were to come to us and say, hey, we have this, it seems to be working very well, we're not going to ask for details, we're just going to accept the fact that he's been given that, or he or she has been given that recommendation and is coming forth with the evidence to support that. And so this is is a technical thing, not necessarily as health related, other than it does deal with most predominantly health records. But we urge your support of Senate Bill 170. I'm also willing to stand for questions at the appropriate time.
Committee, that does conclude our oral proponents. I would direct your attention to written only. Tara Mays, Kansas Hospital Association, Rochelle Colombo, Kansas Medical Society, and Dave Johnston, the president of KEMSA. Committee, do we have any questions for any of the conferees? Senator Erickson.
Thank you, Mr. Chair, and this is for either Director O'Hare or Mr. House, either one, but this seems like a fairly common sense approach to this type of improvement. So can you tell me why the original sunset was put in there? Was it put in there to maybe monitor any specific concerns when the bill was originally written? Or can you tell me why that sunset was put in there in the first place? Thank you.
This is Wendy O'Hare. I'm the director of the Kansas Trauma Program. While I don't have any specifics about why the sunset clauses were put in there originally, my understanding is that that was just par for the course, that when information about protected health information is being discussed, that those clauses are just generally put in and then typically allowed to expire after 5 years.
And Mr. Chair, I might be able to help with that.
Jenna, go ahead.
Yep, it's our practice whenever a public document is excluded from the public, that is just the standard drafting practice, as well as what the statute requires, that the legislature review it every 5 years. Those of you who have been around for a while probably have heard of our open records bill, which reviews all of the exceptions that are about to expire every 5 years and gives the legislature an opportunity to review and either reenact or let those exclusions to the Open Records Act expire.
Senator Thompson.
So Jenna, does that mean that we'll review this again in another 5 years, or does this permanently end the sunset on this thing?
Yes, Mr. Chair, this would mean, at least in this bill, that the sunset would be removed. There are some times when it would be extended for another 5 years if the legislature chose to do that, but the way this is drafted, you would never have to review this one again. It would be permanent.
Okay, I think that answers. Yeah, I was just curious too, Mr. Chair, for one more. How many review cases, maybe this is for Mr. House, how many cases do you review a year, and what's done with that information? How does that information, how to improve things, trickle back out to the healthcare community?
O'Hare, I can answer that question. So the number of cases reviewed a year just really depends on the hospitals that choose to submit a case for review, or the department, the emergency medical services.
Wendy, I am sorry. You are having, you look like you're green and we can't hear you, so I apologize. Joe is standing. Would it be okay if we deferred and let him answer this? Joe, go ahead. Thank you.
So, Joe House with the Emergency Medical Services Board. Ms. O'Hare is actually the best one to comment on the number. The way that it propagates out, there have been a good number of cases over the previous 5 years. I'd say in excess of 10 where we've taken recommendations from the Secretary to in all cases have actually been to sustain what has turned out to be a very good process. And so has sustained the care that's being provided.
Senator Gossage.
Thank you, Mr. Chair. I note in the fiscal note that it says under current law, the authority of the Advisory Committee on Trauma or Regional Trauma Council falls under the Kansas Department of Health and Environment anyway, as this bill indicates. And so there's no fiscal note or anything like that. It's already part of the department. You'd just like to not have to worry about coming back every 5 years to get it approved. Is that correct? Thank you.
Committee, do we have any further questions for any of the proponents? Not seeing any. Is there anyone here wishing to testify as a proponent? Not seeing any. Committee, we also do not have any neutral. Is there anybody wanting to testify as a neutral? Okay, and we also do not have any opponents on this bill. Is there anybody wanting to testify as an opponent? Okay, not seeing any further testimony. Committee, I will encourage you, if you have any amendments that you would like to add to this bill, we are going to try to work this either tomorrow or Thursday and get it out to the floor. So please make sure you have any amendments ready and sent to Jenna so we can get that worked. Committee, this now closes our hearing on Senate Bill 170, and we will now move our attention to Senate Bill 138, where we are now going to open that hearing. And first up, Jenna Moyer is going to give us an overview of the bill. Jenna?
Yes, thank you, Mr. Chair, members of the committee. Senate Bill 138 relates to the certification and funding for certified community behavioral health clinics. And because that's a mouthful, we usually refer to them as CCBHCs. And Section 1A would require KDADs to establish a process for both the certification and funding of these health clinics. Subsection B of this bill would require KDADs to certify any community mental health center as a CCHB if it offers the following services. And then the bill online, let's see, page 1, lines 15 through 22 lists all those services, everything from crisis services, screening, substance abuse services, primary care services, as well as community-based treatment for community-based mental health care treatment for military service members as well as veterans. Subsection C would require the Department of Health and Environment to establish a prospective payment system, either daily or monthly rates to pay for those services. And subsection D would allow the Secretary for Aging and Disability Services and the Secretary of KDHE to adopt rules and regulations as necessary to implement or administer this section. And subsection E would require KDADs and KDHE to implement the provisions of this section not later than July 1st, 2021. And I will note that the House version of this bill, which was almost an exact copy, it's House Bill 2160, was passed out favorably of the House Health Committee, but it had an amended implementation date of May 1st, 2022. And with that, I'll be happy to answer any questions.
Committee, do we have any questions for Jenna on the bill? Okay, seeing none. Jenna, great job. Thank you. We will now move to proponent testimony. First up, we have Kyle Kessler. And conferees, I would just remind you that we do have your written testimony. So if you could just give us a brief highlight of your testimony and try to keep it under 3 minutes. Thank you. Kyle, welcome to the committee.
Thank you, Mr. Chairman, members of the committee. I am Kyle Kessler, Executive Director at the Association of Community Mental Health Centers. We appreciate the opportunity to appear here this morning in strong support of Senate Bill 138. Just so I don't bury the lead, straight out of the gate, I'll tell you that Senate Bill 138 for our system, I believe, is a game changer. There are quite a few firsts for me with this bill, having been around the State House and doing health and human services public policy for about 20 years. It's the first time in my career that I can remember having a one-page bill that I would refer to as potentially the most influential or impactful behavioral health legislation in 30 years, probably going back to the Mental Health Reform Act of 1990 that was signed by Governor Hayden. I think that on the policy side, We see the impact of additional crisis services and services to veterans and the outreach that can be done. This absolutely raises the stakes and requires the CMHCs who become CCBHCs to raise their game to a different level. And we're seeing the impact of this around the country with other states that are adopting this model. I think that another piece that I'll touch on very quickly is the funding side. This allows for cost-based reimbursement for CCBHCs, or Certified Community Behavioral Health Clinics, as Revisor Moyer mentioned. And this would be an infusion of resources for our system. But I also, on that same level, want to mention, another first in my career. I think this is the first time that I have actually expressed public criticism of a fiscal note that was done. We just have a strong disagreement over how the fiscal note was developed for this bill. We think that if you just Google CCBHCs, you will see, in fact, the second to last page of our testimony, which looks like this, is a map of the CCBHCs around the country. And the state of Missouri is the closest to a 100% implementation of their CMHCs into this, and they're in year 5. So we would anticipate at best that this would probably be a third going fiscal years 2023, 24, and 25. So we feel like this is an absolutely important long-term goal for our state. And I would really conclude my comments by saying that this really allows us as a state to provide high-quality behavioral health care across the state in a timely manner. So with that being said, I would also just mention that this was one of the highest recommendations out of the Mental Health Modernization and Reform Committee that recently met, and also was a recommendation out of the Robert Bethel Cane Care Oversight Committee, as well as the Legislative Budget Committee. So that was also another first for my career. And I will conclude my comments and stand for questions at the appropriate time, Mr. Chairman.
Kyle, thank you. In committee, we will hold questions for all conferees until after each conferee has had a chance to speak. Next up, we have Sheriff David Groves, Cherokee County. Welcome, Sheriff.
Good morning. Thank you. Chairman Hildebrand and honorable members of the committee. My name is David Groves, and in addition to serving as Sheriff of Cherokee County, I also serve as the Vice President of the Kansas Sheriff's Association, and I was asked to provide comments on behalf of the Kansas Chiefs of Police Association and the Kansas Peace Officers Association this morning as well. As you all know, Kansans and all of our communities are suffering from mental health crises, and if you were to go back to your respective community and ask any law enforcement professional, I'm confident they would tell you that that crisis has only increased over the last several years. Unfortunately, our community mental health clinics have been unable to keep up with that demand. In certain communities, such as mine, that neighbor 2 states, Missouri and Oklahoma, that issue is made worse because clinicians that are hired and trained here and gain a little bit of experience are able to go across the state lines and make anywhere from $10,000 to $15,000 more a year. The associations that I mentioned previously believe that this bill will help alleviate some of those concerns. And by doing that, we'll be able to allow our community mental health professionals to provide more services to those in our community, including those incarcerated in our county jails across the state. In addition, the passage of Senate Bill 138 would allow veterans and current armed force members to receive specialized services closer to home as opposed to traveling several hours across the state to get the services that they need. Another component that I like about this bill is that it will free up mental health professionals to actually respond to scenes with law enforcement when that's a safe and appropriate option. We currently do not have that availability, which means the people that we encounter in law enforcement that are experiencing mental health crisis, that aren't necessarily committing a crime, but they are experiencing a mental health emergency, they need help now. They don't need a phone number to call and schedule an appointment several days from now. And then there's transportation issues and a whole host of hurdles for them to get the help that they need. We believe this bill will help alleviate some of those hurdles and allow those mental health professionals to respond on scene, again, when safe to do so, and provide at least an initial assessment and services immediately to the people who need help the most at the time they actually need it the most. And that's why, again, the Sheriff's Association, the Chiefs of Police Association, and the Kansas Peace Officers Association are proud to be a proponent of Senate Bill 138, and I'd be happy to stand for any questions at the appropriate time.
Thank you, Sheriff Groves.
Thank you, sir.
Next, we have Sarah Fertig. She's the State Medicaid Director for the Kansas Department of Health and Environment. Sarah, welcome to the committee.
Thank you, Mr. Chairman. Okay. I had the spinning wheel, had to make sure I was live. Good morning, committee. Thank you for allowing me to testify on behalf of KDAG. We appear as a neutral conferee on this particular bill. We believe that the CCBHC model shows some promise, and KDAD's agreed with us. I believe KDAD submitted written-only testimony, so I would encourage you to take a look at their testimony as well. We feel that this model does show some promise in other states. However, it is a complicated model to stand up in Kansas, and it's simply not possible to do that by the deadline contemplated by the current language of this bill, which is July 1, 2021. As Jenna pointed out, the House committee that passed this bill out in much the same language that this one is, bumped that go live date to May 1, 2022 to afford the state some more time to stand this program up. There's a lot of work that the state would need to do in order to address all the federal requirements for CCBHCs. There is a set of standards that CCBHCs must follow. Those are set by a federal agency. KDAD's includes a link to those standards in their written testimony, if you're curious about that. In addition, the prospective payment system that KDHE would be required to stand up also comes with a set of standards that we would have to comply with. And as Mr. Kessler noted, we've had some difficulty pinning down the exact cost of this particular bill, and that's simply because there are a lot of questions about it. A prospective payment system, as Mr. Kessler indicated, is designed to reimburse a CCBHC for the actual cost of providing services. And it's going to be a facility by facility rate. And at this time, the state does not know what those rates would be for each of the 26 CMHCs because we do not have cost report information from them. However, our fiscal note was based on a report that was commissioned by the U.S. Department of Health and Human Services, and they looked at the CCBHC experience in other states. And so our fiscal note is based on those findings, and they found that if you develop a PPS rate on a daily basis, so if a Medicaid beneficiary shows up at a CCBHC, no matter how many services they receive on that day, they'll receive one flat payment rate. In other states that have adopted this model, that rate averaged $234 per visit, but it ranged from $132 to $639. And we really don't know where within that range each of the 26 CMHCs would fall. For a monthly PPS rate, where no matter how many services a Medicaid beneficiary receives from that CCBHC over the course of a month, the CCBHC would be paid one flat rate. That averaged $759 a month, but the range was $443 to $2,043. So it's quite a range. So that's why our fiscal note reads the way it is. And Mr. Kessler had indicated that they think that the actual rollout for CCBHC certification might be 1/3 and a third and a third over the course of 3 fiscal years. However, we would note that there isn't any language in the bill to make that happen. So we believe that there is some promise to the CCBHC model. However, as we noted in our written testimony, there are a lot of details that the state would have to iron out before we could stand this program up. And some of the timelines to get that work done is out of our hands because as with everything Medicaid, we have to receive approval from the federal government before we can implement the program. Our CMS partners have told us that there are some delays in processing applications currently due to the presidential transition. They simply don't have leadership positions filled currently. Typically, it takes a couple months for a state plan amendment to get approved. They're asking for much more time this time around. And it typically takes at least a year to 18 months for an 1115 waiver amendment to be completed, if that's the direction the state would need to go. So that is why we ask for additional time. And if this committee sees fit to pass the bill out favorably, we would respectfully ask that the deadline for the go live match the House bill, and so that we can extend that subsection E deadline to May 1st, 2022. And Mr. Chairman, I would just draw the committee's attention to KDAD's testimony, which essentially says the same thing. And I would be happy to stand for questions.
Thank you very much. Committee, next we have Amy Campbell, Kansas Medical Health Coalition, and conferees, if I could just, I would like to allow enough time for questions from the committee today. If you could condense your oral testimony, that would be appreciated. Thank you.
Thank you, Mr. Chairman. My name is Amy Campbell. I work for the Kansas Mental Health Coalition. We are a roundtable organization consisting of over 50 organizations statewide, and we develop consensus regarding mental health policy in the state. Our organization is supportive of Senate Bill 138, and my testimony goes through some of the comprehensive range of addiction and mental health services that CCBHCs provide. Providing these services will do two things. Number one, it will help close some of the serious gaps in coverage that we have in our continuum of care across the state. It will also provide supportive to our workforce shortage that we're experiencing in the behavioral health field. I have served on the Mental Health Task Force 2 years that the legislature created, and now the Special Committee on Mental Health Modernization and Reform has recommended this legislation. We believe, as Kyle stated earlier, that this is comprehensive, system-wide, and will result in an improvement to services for the entire state. Thank you, Mr. Chairman.
Amy, thank you for your testimony. Committee, we now have Steve Denny. He's the Deputy Director for Fort County Mental Health Center. Steve, welcome to the committee.
Mr. Chair, thank you so much for the opportunity to testify. Are you able to see me and hear me?
Yes.
Thank you. So I am the Deputy Director at Fort County Mental Health Center. I'm here in Independence, Kansas. We serve 5 counties in southeast Kansas. I'll keep my comments brief. In May of 2020, we received a federal Samsa Grant that allowed us to become the first organization in Kansas to pursue CCBHC status and to become a CCBHC lookalike. We applied for that grant for 2 reasons. Number one, we were finding that employee retention was becoming significant. We were losing talented long-term employees to the state of Oklahoma at much higher rates of pay. Number two, allowed us to expand programming and access to services to populations like veterans and crisis services. What we've been able to do is establish some specialized programs as a result of this grant. One of them is Assertive community treatment, which reaches out to individuals with severe mental illness who are at risk for homelessness and legal issues. And we've been able to start serving that population on a more specialized manner. We've had direct admissions from corrections into our system to prevent reentry. We've started to see some good numbers. What the CCBHC really does is it forces you to develop a comprehensive system of care, crisis services, primary health screening, quicker access to services, a non-four walls approach. And we've been in the process of expanding our programming and services to become a CCBHC lookalike since we received the grant. We just completed Q2 at the end of 2020. We're about halfway through Q3 right now. What we've seen so far, I mentioned the success of the ACT program, which is still growing and in development. We've developed a specialized service pathway for veterans. We've served approximately 74 veterans thus far. Last quarter, we served 30 new veterans as a result of our change in our processes and procedures and new pathways. We've developed tobacco cessation intervention and activities. Our population, we found about 40% are actively using tobacco. And if you think about the long-term cost to the healthcare system, the interventions we're doing now could have a tremendous impact on cost for a system. Same thing, we're doing screenings for BMI and blood pressure, making referrals to primary care. And the data is showing us that we're on target to serve around 3% more of the population than we did the previous year, which was one of our goals. And that's during a pandemic and a time when we're having to do so much of our work virtually. I believe, and we believe, that this CCBH system is essential to the future of our system. We believe that the PPS system, while it is a new way of thinking about how we are reimbursed for care, would be game changing in terms of how we can impact clients and not just be driven by how long we spend with clients, but the quality we have to deliver through the CCBHC outcomes that are required. And it also forces us to look at where the services are delivered and what combination of services are most likely to impact and make a difference in our clients' lives. And it definitely produces a focus on community assessment and community partnership. Law enforcement, hospitals, local ERs, all of those things are built into the CCBHC model of care. So I'm strongly in support of this, and I'll certainly entertain any questions at the appropriate time. Thank you for the opportunity to testify.
Dave, thank you for your testimony. Conferees, we have 9 minutes left. I apologize, but conferees are going a little bit longer, and I do want to allow time for committee to ask questions. So again, I'm really encouraging you to please condense because we are going to cut it off at 10 minutes. So next we have Tim DeWeese, Executive Director, Johnson County Mental Health Center. Thank you.
Thank you, Mr. Chair, members of the committee. My name is Tim DeWeese. I'm the Director of Johnson County Mental Health Center. And I appreciate the opportunity to present testimony on this bill, which I would consider the roadmap for improving the health and well-being of the entire state. Thanks to bipartisan support in the U.S. Congress, certified community behavioral health centers are leading a bold shift to increase access to high-quality mental health and addiction treatment, which is making a difference in thousands of lives of individuals across our nation. It is estimated that more than 250,000 Kansans experience serious psychiatric distress annually, and unfortunately, the lack to timely, high-quality mental health and addiction treatment is the greatest barrier to a healthier Kansas. Additionally, people living with mental illness who are untreated are much more likely to encounter the criminal justice system, resulting in a larger number of unnecessary arrests. The issue with a workforce shortage that has been mentioned, so I won't mention that. I think that the other thing that I'll just end on in being thoughtful of our time is that the research is clear that a CCBH designation will place an emphasis on the access to care and the quality of services. In return, the CBHC receives the Medicaid Prospective payment. If you provide access to care and you provide them in a high quality way with positive outcomes, you will see cost containment across the system. Given the increasingly complex challenges challenging needs of individuals and families within our community and the prevalence of drugs and other social problems, it's more important than ever that we have access to services when people need those services. Thank you, and I'll be happy to answer questions at the proper time.
Tim, thank you very much for your testimony. Committee, next we have Joan Tamani, Executive Director of ComCare. Joan, welcome to the committee.
Good morning, Chairman. Good morning, committee members. Thank you for your time. I will be very brief. I'll keep mine to 2 statements. The CMHCs have been very, very strong in serving the highest need population and being able to stretch a dollar farther than most systems of care anywhere. But it's put us at a serious disadvantage. I lose a master's degree clinician on average every 8.5 days because I can't compete financially to keep them. I know we have received funding from the legislature for our community crisis center, and we have done cost avoidance studies every year since we implemented the expansion in 2015. And I will say that we saved the state and our communities an average of $9 to $12 million a year because we're able to treat people locally. And this is what this model is all about. So I will leave it at that, and thank you for your time.
Joan, thank you very much for your testimony. Stacy Manbeck, Executive Director of Spring River Health and Wellness. Stacy, welcome to the committee.
Thank you, Chairman Hildebrand and members of the committee. I appreciate the opportunity to provide support today in support of Senate Bill 138. I want to echo what the others have been saying regarding workforce challenges. It took us nearly a year to fill a clinical position. We do have the challenge of sharing a border with both Oklahoma and Missouri here in Cherokee County. And with the salaries and revenue that they bring in and are able to provide their staff, it is very challenging for us to recruit and retain qualified workforce. One critical thing that I would like to point out here in Cherokee County is although our county is very small and very rural, we only have about 19,939 people in our county. And our service treatment increased by 51% from 2018 to 2019, which is a fairly significant increase in the amount of services that we are needing to provide. And the difficulty in finding and hiring qualified workforce to treat these individuals is so critical to us. We can, with additional funding, we can minimize the wait time. We can hopefully prevent many of the mental health crises that we're seeing, and also be able to respond, as Sheriff Groves mentioned earlier, with local law enforcement in a mobile crisis type situation. So I just want to reiterate and let you know that I do appreciate the support and would appreciate your support in passing this bill in favor of the CCBHC system of care model. Thank you.
Casey, thank you very much for your testimony. Committee, that does conclude our proponents' testimony. We do not have any written testimony except for neutral. That's from Laura Howard, Secretary of KDADS, and we do not have any opponents to this bill. So at this time, we are going to open up for questions. And Sheriff Groves, I actually have one for you. So put you on the spot here. It's not more of a question, but more of a statement, and for you to follow up with it on your firsthand experience. I know me and you have had many discussions about mental health, especially in rural Kansas, especially in our home area of Southeast Kansas. And community mental health clinics are different and serve a different need than what Osawatomie and Larned do. And there is a crunch even further onto the local communities because of the moratoriums that we have and available space that we have for those. There is currently, I can't remember, I think it's 18 waiting lists for Osawatomie currently. So if you wouldn't mind, as briefly as you can, explain to the committee how stressful that is on the community for the police department, the hospitals, the community health clinic, and local citizenry when they're out there witnessing what's going on.
Is it now? Okay. So recently we had a resident who was released from Osawatomie after, I think it was about 2 months, we finally was able to get her in there. After release, within 24 hours, she had started experiencing another mental health crisis. And within a period of 5 days, she had went to 7 different medical facilities in Southwest Missouri and Southeast Kansas. That's a resource on law, that's a response from law enforcement. Each of those transports was done by an ambulance service. It's frustrating from a law enforcement perspective because when someone is experiencing a mental health crisis in a neighborhood, law enforcement's called. And so we respond. And most of the time, a good number of the time, those folks are not committing a crime. They're having an emergency and they need help now, but there is no help to give them. There's nowhere to give them. We can give them a phone number and hope that they call, and later down in the week, they get an appointment and they hopefully will show up if they have transportation, which they probably don't. And so those dealings with those folks typically continue throughout the week until at some point they do commit a crime, and then they're taken into custody more or less for their own safety. But it's incredibly frustrating. We don't want to put somebody in custody that needs to be in a mental health setting, get help from a mental health setting. But a lot of times our hands are tied and there's no alternative.
Thank you, Sheriff. Committee members, we have questions. Senator Petty, then Senator Thompson. Gossage, and then
Thank
Stephen.
you, Mr. Chairman. And this is for Kyle Kessler. Kyle, I know we had testimony today that from the one mental health center that has a grant right now. And so this legislation, which I appreciate you saying, letting us know that the mental health modernization and the Bob Ethel Committee have all recommended this, particularly mental health, of making it the #1 priority. So this, and I would like you to comment on the change of the date that was passed in the House. But this would allow, if with this legislation in place, or if we pass this legislation, it would then allow our mental health centers to be able, I mean, it sounds like the biggest thing is to be able, if they provide those services, pull down the funding.
Yeah, and it's both. Those things go hand in hand, right? You provide heightened level of services, and you also then draw down that funding. So the results of that have been, again, back to the fiscal cost piece. We've seen in Missouri and New York State, which were both interesting. Missouri is so similar to us, New York State not so much, but some of their numbers have been very similar in terms of emergency room utilization. In Missouri went down 20%. Hospital inpatient admissions went down 36%. Those are absolute cost offsets, and those are highest cost drivers in healthcare service delivery today. So yeah, you're right. I think that those things do go hand in hand, and so as it relates to the May 20 or the May 1st start date, the key component of that is the one mental health center that we have that is participating in this, kind of our pioneer, so to speak. They are their grant ends April 30th, and so we would need to stand up the model at least by that date so that they're not live without a net and at risk of training more folks to go over state lines.
Waiver, though, is still an issue. I mean, 1115 waiver would have to be.
However, that's whether it's state plan amendment or waiver amendment, whatever. I mean, we've left that to try to be flexible with the agency on that piece.
Thank you.
Thank you, Madam.
Committee, we just have a couple of minutes, so if for some reason we cannot get to your question, if you would email Donola, and Donola, if you would email to the conferee for who the question is intended to. Senator Thompson.
Thank you, Mr. Chair. I'm not sure who to answer, maybe Sarah Fertig on this one, but is a CCH or BHC's reimbursement rate higher? That's why they can afford to pay people competitive rates as opposed to, Oklahoma? Is that where we make up the difference?
Yes, thank you, Senator Thompson. And that's correct. This would involve a pretty big investment in the CCBHCs, and the facilities who were certified as CCBHCs would be drawing down significantly more money, both state and federal, than they currently are for the services that they're providing.
Okay, thank you.
Senator Gossage.
Thank you, Mr. Chair. I had a similar question. And my question is back to the sheriff, again, if I may. And you were saying the difficulties that you have, which I certainly understand with this woman that you gave the example. How would that change?
Well, if our community mental health professionals are able to respond with law enforcement, once law enforcement arrives, deems the scene to be safe, and that there's somebody that's experiencing a mental health crisis, we would contact our partners with the community mental health. They would respond to scene and be able to provide services right there, as opposed to calling an ambulance, doing an ER. They have to go through the ER, and then in our area, there's just not. Our community hospital is not equipped to service a mental health crisis like that. And so it would be able to put a mental health professional face to face with somebody experiencing a crisis at that time, and they would be able to work through that together, as opposed to going through the hospital in that system.
You're just saying that doesn't happen now because for lack of staff or?
Lack of staff and resources. So if they are able to, again, be competitive with wages, retain staff, that frees up additional staff to respond with us.
Thank you.
Yes, ma'am.
Thank you, Mr. Chair.
Committee, one last quick question. Senator Steffen.
Thank you, Chairman. I think it kind of dovetails in with these others. I'm just trying to, within the bill from that lines 15 to 22, it outlines these services. I'm just trying to get my head around why those services can't be provided in the current setting.
And it all comes down to funding. And Kyle, you want to address that?
Just very briefly, Mr. Chairman, Senator, a lot of it is related to funding and what's reimbursable. So going back to Senator Gossage's question, the emergency crisis services are a requirement to do that. It's one of the additional requirements of a CCBHC. Right now, some of these things we're not required to do. And so if they're not reimbursable, then we don't have the resources to send folks out.
Committee? Thank you, Kyle. Committee, that concludes our testimony and questions. We are going to close the hearing on Senate Bill 138. And committee, we are now adjourned. Thank you, everybody. I apologize. Thank you to my minority